Good morning, good noon, good afternoon. Welcome, everybody, to another Thursday VMR. You might have noticed, if you're paying attention to the email, that following our beloved Rabih's advice, we have scratched the 30-minute rule on these Thursday VMRs. In large part, I think because we're just having way too much fun and don't want to contain that fun to 30 minutes. So if you noticed that on the email, kudos. If you didn't, we're excited to tell you that we're going to borrow a whole hour of your time today. And it's a very special day. It's a special day in many, many ways. The first is that it's been a while since I've gotten to go discuss with David, who I'm very, very excited to share the stage with. But even more special because it's the first time that we're having a friend from outside the CP solvers come through the case review committee and present a case to us. You might have heard of Hu Ting's case on a Friday recently. But this is the first time that we have a friend from outside the CP solvers who is joining us. And so I would love to hear your voice again, Kushal, and tell us a little bit about yourself before you tell us about your case.
Yeah, sure. So I'm an international graduate and I've practiced medicine in India for about 9 years to 10 years. And I knew I wanted to do my post-graduation in the US. In hindsight, it might not be the most sensible thing. So I decided to work with underserved community over there, seeing about 300 patients per week and doing 100
Wow.
surgeries. And I think I was just enjoying my work so much that, and then waiting to come to the US, and I've done all my steps, and now I'm looking to actually match in a residency program. So I'm also working with Presence Hospital Accession as a surgical assistant, and I've also participated in research activities, and I came to know about CPS like a month ago, and it's one of the, I mean, I really look forward to the sessions and discussions which happens, and I've jotted out a couple of cases, and hopefully everyone enjoys today, and I will be able to present a few more cases in coming months.
Amazing. That sounds wonderful, Kushal. Can you tell us a little bit more about where you grew up in India? You have a
So
lot of friends.
yeah, for sure. So I grew up in this coastal area called Chennai. It's got the second largest beach, and it's a little down south to Goa. People might be more familiar with that place. It's very safe. It's a metropolitan city, and it's considered one of the safest cities to go and stay. And so I worked with the Southern Railway Hospital, which is like a central government, and all the railway employees across the it's a free treatment and everything can be done. So it's literally like New Amsterdam. Sure, if anyone has seen, if a person has come who's requiring non-invasive heart replacement and you wanted a C card, and then you just had to go to your chief and let him know, and he would arrange it for you. So it's literally like that, and
Wow.
you could do just about anything you want,
Oh
and
my gosh.
you don't and patients don't get charged for it. It's all railway employees, and railway is I think it's the largest earning um, field in India.
Mm.
So it was an amazing opportunity and experience. So yeah.
Wow. I'm sensing such positivity from you. Everything that you seem to do, you do with such joy and such enthusiasm and passion. And I wouldn't be the least bit surprised if that translates to your case today. I do want to
Yeah.
take a moment to just emphasize what you have done, which is that you went through this process, which I really, really hope that other people will be interested in, which is getting your case through the case review committee. It's a really, really cool opportunity to be here, to present a case, to share that gift with us. The steps are outlined here, mainly about emailing us at this email, theclinicalproblemsolvers@gmail.com. You get to work with one of our amazing team members, and you get to add it to your CV, all of which are important in many ways. But I have babbled long enough. Take it away, my friend. Excited to dive into your case.
Okay, so this is one of a very interesting case, and it happened on December 31st in 2008. So I just remember that so clearly because I was going to step out after my shift, but then we had this stretcher come from an ambulance with a lady who was 28 years old and was bleeding her vagina. So all her the bed sheets and everything was just soaked in blood. And so we checked the vitals. Her pulse was very feeble, and her blood pressure was 80 by 70. And then she was not reactive. Her GCS was around 8. She was like responding to her name, but nothing further. And so when her pupils were reactive, So the only other history which we got from the husband who had come along was that she had a prolonged labor, about 2 to 3 hours in a primary care center, and she was actually delivered by a midwife, and this was a second delivery. So, and that was the only thing, and that happened about 3 hours. They had a 3 hour travel before they could come to our hospital. So it was like literally 5 hours of the whole situation happening. And so that is the first thing. And does anyone want to say anything from about here?
Thank you. Thank you, Gosha. Well, I'll pass the mic to David to reflect on this case. And just for this subsequent data, maybe I can ask you just to watch the person who's scribing, just to match your presentation to their ability to be able to keep up, because sometimes it's hard to type, especially with such an acute case. But I think Aisha and Maddie were able to get everything down. David, what are you thinking?
Well, I don't have a great approach for gynecological bleeding, because it's a kind of patients that I don't see. But well, I think primarily in like two boxes of causes, like gynecological causes and systemic ones. And systemic, we could think of hemorrhagic diathesis, like coagulopathies, and in this patient, I don't know exactly if she had a prolonged labor, how long ago that was, if she's in the puerperium now, or I don't know how long ago was this, but I think we could frame this as a puerperium bleeding, vaginal bleeding, in that could be very, I think, very lethal, probably in this context, with that blood pressure and that overall that Glasgow score, that made me think also in other kinds of systemic repercussion, right? I don't know if I'm thinking just DAC. I don't know what happened in the labor, but would be interested in knowing that information, and if she had any prior history that could point towards any coagulopathy. Yes.
Yeah, no, David, I think you're spot on. I think the vaginal bleeding here is the most important problem, and its consequences are inferred by the degree of shock that this patient is in. As we first try to understand what we're dealing with, it's important to, especially with these very severe presentations, to make sure that you are not distracted and get tunnel vision on one problem when there might be another. And I say that because with a blood pressure of 80/70, you don't expect somebody to be this obtunded. And so for me, I'm wondering whether the problem list is vaginal bleeding, shock, and or altered mental status out of proportion to hemodynamics. So we'll explore that latter hypothesis, why she's so obtunded later, because we have to immediately resuscitate this patient. And we have to resuscitate her blindly to the cause of her bleeding initially, but then ask ourselves what causes vaginal bleeding. And I think you answered that question superbly. It's best to approach vaginal bleeding by first having a split in your schema with, is it in the context of pregnancy or outside of pregnancy? To briefly review what you talked about, the context outside pregnancy hinges on one of three things: a coagulopathy, an endocrinopathy, like hypothyroidism, hyperthyroidism, amenorrhea, so on and so forth, and then anatomical abnormalities, including tumors in the urinary tract. So vaginal bleeding outside the context of pregnancy, coagulopathy, endocrinopathy, or structural lesions identified on exam or ultrasonographic assessment. Bleeding in the context of pregnancy begets two things. Is it uterine or placental? And a variety of placental issues, including abruption, retention of product, so on and so forth. Basically, many, many, many things. And then what is not uncommon is uterine atony, or the uterus does not contract enough to hold on to blood. So those are the two common causes in pregnancy, and you would recognize that the causes unrelated to pregnancy can also manifest circumstantially in the context of pregnancy, or that a pregnancy-induced endocrine or a pregnancy-induced coagulation cascade issue can result in vaginal bleeding simply because the vaginal tissue is the most vulnerable to bleed after the patient has delivered. So where are we at? I think vaginal bleeding is our problem, but I don't think we can lose sight of the altered mental status because the blood pressure is too high to assume that a GCS of 8 can be attributable to it. What could be the causes of bleeding? Those strictly limited to pregnancy would be placental issues or atonic uterus, but as you said, a pregnancy-independent coagulopathy, endocrinopathy, or structural lesion may manifest as vaginal bleeding simply because of the friability of the vaginal tissue in the context of what's happening here. So I think the next steps are, one, acknowledge that I've never, ever been in this circumstance before because I work at a veterans hospital that does not take care of pregnant patients. But if I were to be alone in practice, I think access for this patient is going to be really, really important. And then a bimanual exam, probably an ultrasound, and then thinking about agents to stop vaginal bleeding are high-dose estrogen and beta-2 agonists to help promote uterine tone. Those would be the things I'd be thinking about. But the truth is, I think I'd be on the phone with obstetrics and gynecology ASAP. Since I've talked so much, because this is not a common thing, actually, I don't think we've ever talked about vaginal bleeding on VMR, which tells you what kind of cases we see on VMR. David, any other thoughts that have come to your mind since we have chatted?
No, I'm just thinking of pregnancy-related disorders, like in the spectrum of DIC and eclampsia, and well, also with that Glasgow, the possibility of also intracranial bleeding. If there's a systemic coagulopathy, well, the possibilities of PTP or something like that. But yeah, we have to give more information.
Absolutely. Yeah. I love that. I love that now you're like, I need to connect the brain, and maybe we'll connect it with encephalopathy of hypotension or whatnot, but I think we have to explain the brain independently for now. Kushal, you've got us very, very intrigued.
Yeah, I think
take it away. Why don't you give us round 2?
Yeah, so the discussion so far was good. I think like many of you were like mentioning the things which was going in our head as well. And the first thing we did, like Ravin said, was we did go through the ABC and then secure our way and then made sure her breathing was good. And then her saturation was like 99 even when she came presented. So we weren't too worried about it. But then we still gave her about 2 liters of oxygen just to keep her on maintenance type. And then we got the access immediately because we didn't, the blood pressure was low and the pulse was also feeble. So we got a couple of peripheral access, and we tried, while we were trying to get the central vein. And then we started infusing fluids and then got a blood group and typing, and her typing was, she was RH negative, and that the family wasn't aware of that prior to this. And this was a second delivery. So, and we were also worried about the baby at the same time, but that's for another discussion. For now, then her hemoglobin was low, and also her platelet was low, and we also got the blood, and as well as we started getting the fibrinogen. So thinking about like, that's going to be some fresh frozen plasma also for infusion, just in case, with like more for DIC and the blood infusion. At the same time, we had the obstetrician come in, and we were thinking it could be either sepsis because of prolonged delivery. And so we gave her a prophylaxis of an antibiotic. and uterine contractions, the cricket ball consistency wasn't there. People who play cricket, you would know it's like really hard. So it was a little, it's not completely atony, but it wasn't exactly the way we would like to have it after delivery. So we were concerned whether she was actually having retained pieces of placenta or if there's something else. And unfortunately, since the travel, they didn't really, the obstetrician who did deliver didn't have the notes properly mentioned whether the whole of the placenta was delivered or anything in the notes. So it was from a village. So this was the only information we had, and we didn't really want to do a bimanual immediately because she was bleeding still heavily and she was hemodynamically not too stable to be able to do that. And the next thing was urine. We also sent the urine because health was also another thing we were trying to consider and see whether she had a preeclampsia before and now it's gone into DIC and she's gone into health syndrome. So that was something we were trying to consider, but her urine was, her urine analysis, only 1 to 2 RBCs were there, otherwise it was within normal limits. And her liver enzymes were within normal limits too, and but the prothrombin time and PTT are all increased, and her platelet count was lower. And the peripheral smear, there was a little bit of hemolysis there. So that was that for her. So we were still, and her past medical history, no history of seizure, no history of any hematological conditions in the past, and no known infectious diseases for which she was treated during the pregnancy. And family history, no bleeding history in the family, except for the fact that the husband was a lorry driver. And in India, in our clinical setup, whenever our husband is a lorry driver, HIV and sexually transmitted diseases are very high risk, and that's something we would be concerned about. So we also were trying to get her tested for all the STDs because it could be undiagnosed, and that was in the physical examination. She was pale. And we also got the scan done for the abdomen and ultrasound, and the uterus was not fully contracted, but we couldn't really see anything. No, we didn't really see any big pieces of placenta or anything else inside. And yes.
Yeah, shall we stop here, Kushal? You've given us a lot of information to reflect on. Is this a good time to stop and reflect?
Yes.
Okay, excellent. And maybe I can just ask you one clarifying question, which is when you said the smear showed evidence of hemolysis, can you share with us what you mean by that?
She has cystocytes.
Cystocytes. Okay. Okay. And did she have any other findings or just cystocytes? As far as you remember, I know it's from 2008.
I think that's all. That's the only thing he said, and that's fine.
Okay, that's perfect. Thank you so much. All righty. David, what are you thinking?
Just one question, Kushal. What was the fibrinogen? You know the level?
Fibrinogen. Fibrinogen, did you say? No, no, I don't remember that. I remember her platelet count was low, and then prothrombin time was low, and then partial thromboplastin was low, and ATTT was also low. Oh, sorry, I. D dimers were increased, PP was increased, PTT was increased.
Okay. So, well,
Did you say fibrinogen?
Yeah.
Oh, yeah, fibrinogen degradation products was decreased.
Well, this it seems like an hemorrhagic shock. I'm a bit lost with the hemolysis part, but I'm thinking primarily of DIC and DIC-like pathologies. In this context, I don't know, maybe the possibility of an amniotic fluid embolism is another possibility. I assume she didn't receive any drug during the labor or the pregnancy that could cause any coagulopathy. the liver doesn't seem to be also the source of the coagulopathy. And yeah, I'm thinking like primarily in DIC or similar similar syndromes. There's no, I think there's no another possibilities of inhibitors or of anticoagulants or factors 5, 10 to I don't think we have to think of this in the actual moment, like because the context of the preparing is like driven us to the other side. But yeah, I don't know if how to make progress now, but
David, I completely agree with you. And I think it's probably a tension that everybody's feeling. So I think it's probably a good time to go into breakout rooms and articulate what people are thinking. But as I set them up, I would love for you to kind of take a step back and just teach all of us how you came to the conclusion of a working diagnosis of DIC. So I know that for you and how seasoned you are, that's a very simple leap that you took. But maybe for the audience who is learning how to diagnose DIC, can you share with us how you arrived at that working diagnosis of DIC?
well, to me, this seems to be a coagulopathy. And with the elevation in the PT and PTT, the both sides of the population cascade make me think of yeah, well, or any defect in a factor or inhibitor in a factor shared by both sides. Any pathology that I think is not probable here. Any drug like warfarin or well heparins if very over treated, to say it like that, could also cause coagulopathy that alters both pathways. But DIC is I think another possibility given the both alterations, and in this context of perperium, I think is the main one.
Beautiful. Thank you so much for breaking that down so clearly for us. Alrighty, y'all. I'll put have you all go out and breakout rooms, discuss this, see where you're at. And then for those of you listening on YouTube, I think it's a good time to slow down, collect your thoughts, and then we'll come back and I'll share my thoughts and we'll learn more from Kushal. Alrighty, y'all. Let's learn. Hi there. We're in breakout rooms right now. It should be done in another minute or so. Thanks for joining. Hi, for those of you who are just joining, we're almost done with breakout rooms. Hi, Andrea. Hi, Karen. Hello, hello.
Hello.
Nice to see you again. Thank you for joining.
Hi.
How's your day going?
Very good. Very
Good. I'm
good.
glad to hear that. Very, very glad to hear that. All right, I think folks are almost back. Nice hat, Mario. Is it cold?
Hi, Robbie. Yeah.
It's winter time, huh?
Italy.
Ooh.
Presenting
What's
Italy.
the story? How come? How come Italy?
My grandfather from father's side is Italian, so
Oh, really? I didn't know that. That's awesome. Yeah, I always forget. The warmer it gets here, the colder it gets for you. So, all right. Well, I hope you guys had a really good discussion in the breakout rooms. I think this case is really, really intriguing, and I'm so grateful to Kushal for bringing it to us today. I'll just share my thoughts really quickly, and I think, David, you make it a really good case for the presence of DIC. You know, at the end of the day, when you have the combination of thrombocytopenia and schistocytes, you immediately should invoke the working diagnosis of a microangiopathic hemolytic anemia. So MAHA, so low platelets plus cystocytes equals MAHA. The most common cause of MAHA, microangiopathic hemolysis, is DIC, and the characteristic feature of disseminated intravascular coagulation is the presence of a microangiopathic hemolytic anemia and the presence of a coagulopathy, here the elevated PT and PTT, along with decreased in fibrinogen and increase in D-dimers. And there's a very nice table up to date that shows you how confident you can be that this person has DIC. If we step back and ask ourselves, what is DIC fundamentally? It is an imbalance, a complete loss of control of the coagulation cascade. So what happens is you lose the ability to stop your coagulation cascade from acting and forming clots. So what happens is all the clotting factors get together and they form clots, so you thrombose, but you have a consumptive coagulopathy, which means that you drain your resources so much, you lose factor so much that your PT, PTT become high and you have the propensity to bleed. But folks, that common story that we're often told is incomplete because there's a whole separate part of it too. But I want to make sure that we're all on the same page about chapter 1. Chapter 1 is the most commonly taught one in school, which is you have a consumptive coagulopathy. Something activates your coagulation cascade. You form all these diffuse microthrombi, and those microthrombi have consumed so much of your clotting factors that you get an acquired consumptive coagulopathy. And we see both of those things in the initial labs. You've made so many thrombi that your platelets are all consumed in the thrombi, and your coagulation factors are consumed in the thrombi, that both of those things are low, and now you're at risk of bleeding. But that, again, is only part 1. What's part 2? Part 2 is you also have the inability to stabilize the clot that you have. It's called hyperfibrinolysis, meaning that the clots that you make, they're also unstable, and the patient has an even higher increased risk of bleeding, fibrinolytic DIC. So as you can see, it gets very, very complicated, but I'm making this point because it's helpful to try to classify your patient with DIC into overtly thrombotic or overtly bleeding. Why is that important? It actually gives you tremendous insight into the possible causes. Most overtly thrombotic DIC is from infections. It's those patients with sepsis and purpura fulminans who clot off their limbs and get acrocyanosis. Hyperfibrinolytic DIC is a smaller, less common manifestation of DIC that occurs as a result of some unique cancers, one of which we talked about last week, APML, acute promyelocytic leukemia. And importantly, it's part of the manifestation of obstetric causes of DIC. So in this patient, the reason to suspect DIC isn't just the labs. It's because of the clinical context of an acute obstetrical emergency. So the question really is, what kind of obstetrical issues cause DIC? And I think David hit a home run. It's really, really important to think about the eclampsia spectrum disorders, including HELP. It's important to think about amniotic fluid embolism, placental abruption, chorioamnitis or sepsis involving the placenta. Even delayed postpartum hemorrhage can ultimately evolve into DIC. So how do we make progress here? I think we have a working diagnosis that this patient has diffuse disseminated intravascular coagulation. And I think the next steps are to try to understand what obstetrical issue is at play. But I think we can call this hyperfibrinolytic DIC, bleeding, and in an obstetrical circumstance. So I think the next steps are very, very, very tough. I'm really, really curious how, Kushal, you and your team navigated this very life-threatening diagnosis.
One which we had was which became very clear was that she was not having one issue causing the DIC, but probably multiple things happening because of, so one was like prolonged delivery can cause sepsis. So she probably had underlying sepsis going on regardless of what are the other things she's having. And the second was the uterus was still not becoming cricket ball consistency. So we were thinking, though the ultrasound was normal, but there was no notes to specify that the placenta was delivered in toto, so we just didn't know if there were just small membranes can be there in the uterus, they would still be considered retained placenta, and that can actually cause this problem. So that was also another thing which were like high on the list of the diagnosis which we had. And the other thing which we were also having was that STDs which was not diagnosed before. So that can be, that's again the sepsis, and then just the blood loss, like postpartum hemorrhage. And one other point which we were thinking is like sometimes pre-eclampsia they can have also normal blood pressure, low blood pressure. They just not necessarily have always a high blood pressure. Well, that was like one of the obstetricians' take on the whole thing. But the urine protein was, that's usually, at least we would want that positive to get to that diagnosis, but she was not having a positive urine protein as well. So we started monitoring her urine output and we gave her fluids, but then whatever they're losing is what we need to start giving. So we started giving her also blood and started giving her FFPs and fibrinogen. And after about a couple of them, a couple of packets, she kind of like stabilized, but then she was not stable enough to take her to the OR. So we just decided to do the bimanual examination in ICU, and then we did find that she had retained pieces of placenta membranes, which we removed for her. And we then, so once we did that itself, she became a lot more better and her condition started to stabilize. and her urine was always clear, which was good. And then we gave her antibiotics, and she never spiked any temperature, and her GC started improving after that. So that's how we managed her, and she did survive in the end of it.
Wow, what an intriguing case, Kushal. Maybe I can hand the mic to David to see how he's putting it together and how he's processing all this very unusual VMR case. What do you think, David?
Well, I'm not used to this kind of cases, less in pregnancy, and yeah, I don't manage a lot of in cases, so always difficult for me. But yeah, I learned a lot. I love your discussion, Rabih, related to hyperurinalytic DIC and thrombotic DIC. I didn't know that. And well, I have some questions that I would have to read more. But yeah, one question just for you. Would you expect intravascular hemolysis, right, in this context? The urinalysis
Yeah.
says here 1-2 red blood cells. Wouldn't you expect like more hematuria in this context, or why do you have any explanation for that?
Oh, because it wasn't like a frank hematuria where probably like a kidney was shutting down or anything like that, but it was just 1 to 2 RBCs, which can happen also in postpartum period. We just wouldn't know if it was,
Yeah, I think at the end of the day, it's the question that I think David is getting at is a really important learning point, which is whenever you have a microangiopathic hemolytic anemia, you have hemolysis in the blood vessels, and that hemolysis in the blood vessels results in hemoglobinuria. Yeah. And so the way you would diagnose hemoglobinuria is you would see that the urine dipstick has blood picking up the hemoglobin, but that there are not that many RBCs. But David, you can imagine in this situation when somebody is so critically ill that it's hard to study the urinalysis with such close precision, because when somebody is hypotensive and whatnot, it's very, very, very hard to be able to pick up on subtle signs of hemolysis. And at the end of the day, hemolysis is the diagnosis of hemolysis is a synergistic diagnosis. There's no one test that tells you that a patient is hemolyzing, not one single one. Even if you have a positive Coombs test, it could be incidental and related to prior transfusion. So you have to put the story together. You can have hemolysis with a normal bilirubin. You can have intravascular hemolysis with a normal UA, because these tests are not perfect. And I think we can come up and try to explain why the test is not perfect. Maybe the patient has had, as Kushal was just saying, acute tubular necrosis and has no urine output. So if there's no urea, there's no hemoglobinuria. And so, yeah, I think the pathophysiology would push you to look for that. However, I think real-life test characteristics, especially in a critically ill hypotensive patient, make you wonder why you might not have seen it. But David, I think what you're showing us is just your tremendous desire to learn and grow more, because your response to aliquot 1 was coagulopathy, coagulopathy, coagulopathy. And then your response to aliquot 2 was DIC, DIC, DIC. And then I think that what you're saying is the growth for both me and you is to understand better DIC in pregnancy and DIC in obstetrical disease, which neither you nor I are experts in. And I think what Kushal has done for us is given us the gift of thinking through this case, but also teaching us how to think about this and inspiring, hopefully, many of you to read more about this and get more comfortable with it the next time. So I'm very, very grateful for you, Kushal. I'm curious, how was it presenting? How did that feel?
It was actually good. I enjoyed.
Wonderful.
And I also learned a lot.
Wonderful. Well, really, really enjoyed you having here. And I know you have cases maybe from even earlier than 2008, and we can't wait to learn from them. But we get to do one more round of learning with Umaima, who will take us through the teaching point.
Thank you, Rabih. Thank you, Kuchal, for the wonderful case. It's my first OBGYN case with CP solvers, and great discussion, David. Okay, so for the teaching points for this case, we started with the chief complaints of vaginal bleeding. And in vaginal bleeding, context matters. We have to see whether it is happening in the context of a pregnancy or outside of a pregnancy. If it's in the context of a pregnancy, we should suspect uterine causes or placental causes like placental rupture, uterine atony. And if it's outside of a pregnancy, it should raise our suspicion of a coagulopathy, endocrinopathy, or structural lesions. And these causes outside of the pregnancy can be induced by pregnancy, so we should keep an open mind and look for them as well, even if it's an obstetric patient. For postpartum bleeding, Sergio shared a very interesting mnemonic of the 40s. We have trauma, tone, tissue, and thrombin. And to manage this vaginal bleeding, you should give patients beta-2 agonists and estrogens. Rabih raised a very important point about the blood pressure in the 80s and 70s and how it can't really explain the altered mental status, which made us suspicious of another underlying cause other than the hemorrhagic shock due to delayed vaginal bleeding. David was very right from the start. There was a coagulopathy, and the patient had low platelets with schistocytes, which was a synonym of microangiopathic hemolytic anemia. And we had a high concern for the IC with the low platelets, high PC, PCT, increased D-dimers, low fibrinogen, and the schistocytes in the smears. And Rabih taught us that it is a consumptive coagulopathy because we keep forming multiple microthrombi, but the story doesn't stop here because we can't stabilize them. And in DIC, and this is new to me, in DIC we have two subtypes. It can be either dominantly thrombotic or hyperfibrinolytic. In the thrombotic DIC, we should suspect mainly infections. It's the kind of the DIC that we develop in the context of sepsis, or it can be hyperfibrinolytic, like with cancers, like APML, or obstetric causes like uterine rupture, HELLP syndrome, and delayed postpartum hemorrhage. David, directed our attention to the 1 or 2 red blood cell on the urinalysis, and we talked briefly about how MAHA can cause hemoglobinuria, and a dipstick is not always enough. We should follow up with the urinalysis to see whether it was RBCs or hemoglobin.
Absolutely incredible. Wow. That was so concise and so well outlined. Thank you so much, Amara. It really distilled it down to 3 key components. Well, thank you all for hanging out. If you want to hang out in breakout rooms and debrief, ask questions, I'll try to join some of the rooms, but no pressure. Feel free to log off. But if you prefer to stay and debrief, socialize, reflect, we'll open the breakout rooms, but I'll stop the recording now for those on YouTube.